Thank you both for coming on the show this morning.
Thank you.
It's good to have you in our studio.
Thank you.
Yeah, let's look at it this way. From the introduction, we learned that mothers in most primary health care, not just in FCT across the country, sometimes queue up endlessly for vaccines that are not just there, and also probably the perception of the public. Tell us, what has been your experience on the field so far?
Okay. Thank you so much, viewers, for having me. I want to say that, yes, quite okay. Women will line up in the facility to access basic health care in the primary health care facilities, including immunization. But the issue here is that we all know that there is constraint of healthcare workers due to the drainage of healthcare workers abroad and leaving the country with shortage of manpower, especially the skilled manpower in Nigeria. And FCT will not be exceptional on that. Because of that, you see that the services where we're supposed to have maybe 4 nurses or community health extension workers handling, you may end up having 1 or 2 handling, or we may end up in the entire health facility is only 1 person improvising to do all the services for the people that comes to the facility. Because of that, the people in the community has to line up, has to stay longer than necessary because manpower is not there. In terms of availability of vaccine or essential medicines, though we have shortage of essential medicines, and the vaccines are also available, not as such, but honestly speaking, the availability of this vaccine is always there because they improvise, because the immunization, the routine immunization is a one-day something that happens within the week. Each facility has a particular day they arrange for the vaccination. So they make sure that they collect the vaccine either from the state store down to the area council store, then to the service delivery point in the facility. So they rationalize the vaccines according to the days of vaccination. Some facilities will be on Monday, some on Tuesday, Wednesday, like that. So they cycle among themselves and rationalize the availability of vaccines as well as the cold chain. In terms of services, all other services rendered, especially on maternal and child health, are available in the facility. It is the manpower. The issue, great issue, is the manpower, availability of this
challenge,
manpower.
Dr. Wamako, I would like to ask, is accurate data. I hear that this is a big challenge as well in tracking immunization efforts. Without it, how are you able to know communities that are being left behind? And in the case that you have data, who provides this data and how do you verify the accuracy of the data that you've collected?
Usually the vaccine or routine immunization, the data is being generated in the facility by those giving the services. We have the HMIS registers there. We have the tally sheets there. As they vaccinate, they tally in and they enter into the register. And then the daily register will now feed into monthly summary form register. And then the people, that the M&Es that comes to collect the data on monthly basis will now feed it into the DHIS2. This is how the sequence goes. So now, on the other hand, during the SIEs, that is during supplemental immunizations campaigns, what we do as they goes into the community, either house to house or at the fixed post or temporary fixed post, they collect this data into the tally sheet and follow the same channel into the register, and then it now goes to the DHIS2. So with this now, by the time this collation has been made and it goes into the DHIS2, the data now sometimes you see that some facilities that are doing routine immunizations or during the SIEs is not captured in the DHIS2, including private facilities. So there is need to expand that DHIS2 so that those facilities can be captured 100% and then the data goes in there. But actually, we collect the data and then we analyze and then it's been posted to DHIS2, which is the national platform for collation of data.
Okay, Dr.